progress. I'm going to deal in my presentation on decision making and evidence-based therapy in terms of bone regeneration. So I will be dealing with the treatment of extraction sockets and also with lateral bone augmentation. And of course, every day of many days, we have to take teeth out. And of course, we take teeth for a reason. And most of the time, there is pathology behind when we have to extract. And therefore, it is very important that the decision, what is going to happen next? Are we going to place an implant? Are we going to rebuild the alveolar crest? What is going to be the damage to this when the socket is going to heal? What are going to be the consequences, mostly when we are dealing with the anterior maxilla? So one of the important issues that we fully understand today is that irrespective of the background pathology, there is always going to be dimensional changes of that crest, both in the apicocoronal as well as in the bucolingual dimension. But of course, you need to realize that every socket is different in the anatomy. Ideally, we would have a well-preserved socket, and how you can see in the image that you have very thick crests, and the situation, of course, in this particular case is very predictable. But we may have sockets that have very thin crests, sockets that have very specific anatomy, and we need to understand what are the consequences when we allow those sockets to heal. Of course, we have heard about the concept of pressing the bone, which is obvious in terms of biology, but also you need to understand that the socket bone partially is bundle bone that belongs to the periodontal ligament, and irrespective whether we pressure more or less, that bundle bone that belongs to the periodontal ligament is going to be lost, and that is going to change the dimensions of the socket. So you see here on the screen the bundle bone that is facing not only the tooth, but is also at the tip of the crest. And therefore, depending on the amount of this bone, you will have more or less vertical or horizontal dimensional changes. In our research group, we tried to understand what were the early healing events when we do an extraction socket. So in an experimental model, we evaluated the biological changes at 4 hours, 1 week, 2 weeks, 4 weeks, and 8 weeks. And what you see in the screen is the two-dimensional reproduction of the changes. And what you can see is in the buccal bone, which is the bone that you have to your right, you are going to have very important changes, mostly horizontal changes, and mostly in the most coronal part of the alveolar crest. And therefore, it is very important to understand that these dimensional changes depend a lot on how thin, on how thick that crest is. This is a study coming out from Bern, where they have evaluated the dimensional changes depending whether the crest is less than 1 millimeter or more than 1 millimeter. And they have seen that the difference is immense, because when you have very thin crests, you are going to lose, as you can see, basically 60% of your horizontal dimension of the crest. and you also are going to lose a very important vertical dimension. However, when you have very thick crests, there are very small changes. So the issue is that when you are working on the anterior maxilla, irrespective of how clean you do your extraction, irrespective of how gentle you are with your surgery, the thin or thick crest is going to modulate the amount of dimensional changes that you will have. And in the anterior maxilla, basically we have many studies that agree that basically over 75% of the time, the crest is going to be less than 1 millimeter, and therefore you are going to have important changes. Maybe that those changes will allow you to place a dental implant, but irrespective of that, you are going to have a depression and you are going to have an area that is going to have an aesthetic problem. Can we avoid these buccal changes? Can we do something? Of course, we are investigating the biology of the socket healing. And this is just one study that we are doing together in collaboration with Yonsei University in Korea, trying to see whether if we can improve the biology of the healing, in this case using low-dose biphosphonates, in a way trying to inhibit the osteoclastic resorption of that buccal bone. And of course, by doing a controlled experiment, we evaluate the added effect of, in this case, this modulator of bone resorption. And in that way, we can see that yes, indeed, we can modulate the amount of buccal bone resorption in these particular experiments. But of course, this is experimental work. In our daily practice, we need to take an option, and we need to decide immediately when we do the extraction is whether we are going to try to preserve the dimension of the crest, or whether we are going to place a dental implant immediately, or whether we are going to wait and allow the socket to heal and then place an implant at a later stage. And these decisions are very important. So basically, the first of the decisions is, am I going to preserve the ridge or am I going to do immediate implants? And this, again, is important. And these decisions should be made if we have a maintained socket. So that is that I have a maintained buccal wall, that I do not have to build it up. So in that situation, my goal is to preserve. However, as you can see in the slide, irrespective what I do to preserve, most of the time I'm going to lose. And most of the time I'm going to lose because of physiology, because the bundle bone is going to resorb. Is there anything I can do to maintain? Is there any bone grafting material that I can place? And of course, the answer has to come from controlled studies. There is no other way that you can demonstrate anything if you don't do controlled studies. And controlled studies, of course, if you use histology, need to be done in experimental animals. And if you do clinical outcome measurements, have to be done in humans through clinical trials. Without clinical trials, there is nothing we can say in terms of efficacy. The clinical trials that have been done in experimental animals in order to understand what is the best bone graft material or biological. We were talking before about PRF. What is the best to preserve the crest? Well, it is clear that both synthetic biomaterials, combinations of ceramics and also xenogenic bone, are the ones that have proven to to preserve the dimensions of the crest. What about humans? What about the clinical side? Of course, again, efficacy has to be proven by clinical trials. About 5 years ago, we undertook and we published this systematic review where basically we asked ourselves a very simple question. What is the added effect of placing something in the socket to preserve the dimensions of the socket? The only way I can prove the added effect is if I have a control group that I don't place anything in the socket. And of course, if I randomize, because if I don't randomize, it's like doing nothing because I am biased to what I place in the socket. So how many of these clinical trials are there in the literature? Well, 5 years ago, there were 14 clinical trials, which is not too bad. At least I have something that I can compare. And in these 14 clinical trials, when I do the meta-analysis, I can say, yes, indeed, by placing something inside the socket, I can have less horizontal resorption. You see about 2 millimeters, and I have less vertical resorption. You see about 1.4 millimeters. What is the critical factor? Is there something better than other in terms of protecting? Well, when we did the meta-regression, that is to understand the difference between those that have the best to the worst results, well, what we saw is that it is very important that the biomaterial that we place inside the pocket either slows very slowly or does not resorb during healing. And the other very important factor is that I need to allow for primary closure. Because if I don't close the opening of the socket, then of course I will get contamination. And if I get contamination, because you have to realize that irrespective of what we do, in the oral cavity there are millions of bacteria. So to avoid the contamination, we need to do full closure of our flaps, and this of course can be accomplished either by placing a soft tissue autograft or a soft tissue substitute, or basically by advancing the flap. So of course today, with this evidence, we have several protocols that allow us to basically indicate this approach in specific circumstances. Would I do ridge preservation in every situation I do an extraction? Obviously not. But I would probably recommend in highly aesthetic situations where I have very thin buccal bone and where I need most of the crest to be preserved. And basically in these situations, I would use a slow resorbing biomaterial, either xenogenic or synthetic, and I would close the opening either with a soft tissue autograft or with a soft tissue substitute. But the whole objective is to avoid the contamination of the biomaterial that I have placed. And of course, if I do socket preservation, I need to wait. I fully agree with Professor Sokrun. You cannot run in oral surgery or periodontology. You have to wait, you have to allow the bone to grow in order that you have a good mature bone to place your implants. So it is clear that if you do socket preservation, you need to wait at least 4 to 6 months before you can place your implant. But the idea is that you are able to preserve the hard and soft tissues, and you have the best situation to place your implant and to allow an aesthetic restorative outcome. So there is a place for socket preservation. Also in my mind, there is a place for socket preservation when I have to do an extraction in a periodontitis patient. I am a periodontist. And my goal, my job, is to preserve the natural dentition. And I do the most I can do to preserve the natural dentition. But there are situations that I cannot do more. And you see these upper premolars have reached a situation that they cannot stand in the oral cavity. And the problem I have is that I have a very thin buccal bone, and of course I have the floor of the sinus. So clearly, if I allow this to heal, I will lose the whole horizontal dimension, and of course I will have not space because I will need to do a sinus elevation. So in these situations, of course, again, I'm going to use my slow resorbing biomaterial. I'm going to place my membrane, and of course that will allow, with due time, for the socket to be preserved. And you see the starting point, and you see if I wait 6 months, I will have a full restored crest that I can place my implant. And of course you see that I have thick bone, and I have a situation that I don't have a problem to place my implant. So basically, very succinctly, these two indications I think are justified, and I have the evidence that I can preserve the sockets in very aesthetically demanding situations where I have very thin buccal bones, and in the posterior maxilla where I have very thin bone and I have not good bone to stabilize my implant. So let's make the second decision. I'm going to basically do an immediate implant. And of course, to do an immediate implant, I need to have intact socket walls, because if I don't have intact socket walls, I am going to lose much more than I am going to gain. So in these situations, it is crucial to me to have the intact socket, that I can place my implant in the best possible position. And I have to understand what happens with the bone at the buccal and palatal side of the implant that I have placed. Of course, the immediate implant in fresh extraction sockets is a very attractive protocol. It's attractive for the patient because the treatment is reduced. It's attractive for the surgeon because basically what you do is to shorten your treatment time. But the problem is, am I sure that the width and the height of the alveolar bone are preserved? The question is, can I achieve the ideal implant location all the time? And for answering these questions, of course, I am not telling you how skillful I may be in my surgery. The only way I can answer these questions is with clinical trials. As you can see, this is the amount of research that has occurred in immediate implants. And you see, it's huge what we have learned in the last, I would say, 5 to 10 years. And we have learned both the biology and, of course, the clinical outcome. You see in the slide, you may place your implant in the proper position. You may have a beautiful convex buccal bone wall, but at the end of the healing, you will end up with a very thin concave buccal wall. And you need to understand how much, and you need to understand under which circumstances. One of the questions that we had when we started to investigate this protocol is, what is the added effect of placing an implant? Do we have very good evidence that placing an implant in the socket improves the dimensional changes that would occur if I don't do anything? So does it make sense that we first compare in identical sockets what happens if I place an implant and what happens if I don't? So this is what we did. We went again to experimental animals where we were able to have matched sockets, and then we place one implant and we place nothing. And also we wanted to understand, is it the same each particular implant? So we compared 4 different implant designs, because we might think, well, this particular implant is more suited for immediate implants than the others. And of course we measured very carefully, doing control histometric analysis, the amount of vertical resorption and that happened in the socket that healed by itself, and of course we did exactly the same in the socket where we place our immediate implant. You see, when we don't do anything and we measure the vertical dimension of the change between the buccal and the palatal walls, we lost 1.20 millimeters vertically. And you see here 2 sockets, one that didn't lose anything and the other one that lost quite a lot. So there is quite a high variability in how sockets heal. What happened in the implant sites? Well, we didn't lose in the implant sites 1.2, we lost 2.3. So as you can see, when we compare the sockets without and the sockets with, the implant does not help to maintain the dimensions of the socket. And you see some examples with different implant systems. This is with a Stroman, and you see the adjacent socket and the socket we place this tissue level implant, and you see in the buccal side the loss up to the first thread. You see, this is the typical external edge connection, Branomark style implant, exactly the same. So, as you can imagine, there is not a real advantage. We wanted to go a little further. So we did a real controlled study, exactly under the same circumstances, comparing placing an implant or looking at the socket, because we wanted also to understand not only the vertical dimensional change, but also the horizontal dimensional change, mostly in the most coronal part of the buccal bone, which is the critical area. So we went and we measured, and you see, in the most coronal part of the buccal bone, if we don't do anything, we lose 40% of the horizontal dimension. When we place an implant, we lose 65%. So as you can see, it's not a very good idea. If we think that immediate implant preserves the walls of the socket, can we do anything to counteract these changes? What is the clinical evidence? Because I'm sure many of you are thinking, and I also think, we don't treat experimental animals, we treat patients. So again, what is the clinical evidence? Well, the first, normally nowadays in medicine, in dentistry, is we go to a systematic review where they have gathered, put together all the clinical trials on the subject. And this is what Professor Lang did some years ago, and he could identify 46 studies, out of them 10 randomized clinical trials and the rest prospective cohort series. And what we saw when comparing immediate implants versus delayed implants is that yes, it works. It works in terms of survival rate, it works in terms of maintaining the interdental bone levels, it works in terms of maintaining the health of the peri-implant tissues. There are no difference. The only problem is that we don't have good way to evaluate the buccal bone clinically. Nowadays we may use CBCT, but even with CBCT there is not good way to evaluate the buccal bone. And therefore the problem is the aesthetic consequences which are related to the buccal bone, mostly in the anterior maxilla. And what it was clear when evaluating the aesthetic outcomes, in the very few studies that had evaluated the aesthetic outcomes, is that, as you can see, in 1 out of 4 or out of 5 patients, there was an aesthetic problem by using this protocol. And then, about 8 years ago, we had a meeting where, together with Jan Linde and Klaus Lang, we gathered the three of us and said, how can we understand what happens in this protocol? And we designed a series of clinical trials. You have in the screen all the publications that we have done in the last 5 years. But basically what we wanted to measure very closely is what happens with the buccal bone during the first 4 months of healing, from the time we place an implant to the time we put the prosthetic restoration. And we measured the bone in the 3 dimensions of the space. And of course we had to raise a flap in order to measure. But in that I fully concord with Professor Shukrun. The issue to lose the bone is not raising or not raising the flap. So we measured, and of course what we saw is that if we don't do anything, if we don't place anything, just the implant, and we allow that socket to heal, we are going to lose about 1/3 in the horizontal dimension. One of the questions that we all have had asked ourselves, what happens with the gap? What happens with this space between the implant surface and the inner surface of the buccal and the palatal bone? Well, the gap closes because we understand the biology. If there is a blood clot and that blood clot is stable, bone will form and the gap will close. And this is what basically we saw. But what we saw is that there was a huge difference depending whether the buccal bone was thick or thin. Irrespective of the size of the gap, when the buccal bone is thin, what we are going to have is basically double the horizontal bone resorption. And when we compare what happens with very small gaps, less than 1 millimeter, or what happens with large gaps, more than 2 millimeters, what we saw is that we lose more bone when the gap is very narrow. Why? Because the bone is too close to titanium and the blood clot doesn't form, and therefore we don't get a good healing. So to have a space is not bad, all the opposite. To have a space is good because the gap will fill with bone, but the problem is that the buccal bone from the outside will get in and will get horizontally resorbed. So there are situations where I have very thick buccal bone, and what will I get? Almost an identical result to the beginning, because there is very little resorption, irrespective how big that gap is. And the way we did it is, since we have a clinical trial of more than 100 patients, we were able to do multivariate, multi-level analysis that allow us to understand exactly which were the critical factors involved in the horizontal dimensional change, in the vertical dimensional change, and what happened inside the socket, that is what we call the gap. And as you can see in these videos, which are done with the algorithms from the multivariate analysis, the two key factors are the thin buccal bone and how close we place the bone, the implant to the bone. If we place the bone close to the buccal bone and that buccal bone is very thin, we are going to lose, as you can see, most of the buccal bone. We are going to have an enormous change. However, when we have thick buccal bone, more than 1 millimeter, if we are able to place our implant palatally, then we are going to lose very little. So you can see, by understanding the factors, you may turn a protocol that works beautifully into a protocol that works not so beautiful, because you are going to have quite a lot of resorption. So you have situations such as in this premolar situation, where we have a very big gap, we have a thick buccal bone plate, and what is going to expect 4 months later? Everything is filled with bone. We didn't lose vertical bone, and of course, if we follow this patient for 3 years, we are going to have a reasonable aesthetic outcome. Even in situations such as this, that I have a very big socket, that I have a gap of about 5 millimeters, I don't care. 4 months later, this is going to be filled with bone. And of course, since the buccal bone is very thick, 4 months later, I will have a situation that I can preserve the bone vertically, and you see 3 years later, I have good papillas, a good emergence profile, not a problem. But the issue is that in the anterior maxilla, the buccal bone is not thick, the buccal bone is very thin. So the question is, can I maintain the buccal bone if I place a graft? Because of course, you have been thinking all the time while listening to me, why doesn't he place a graft? And then I ask you the same question that I asked myself together with Jan Linde one day in Göteborg, having a nice beer. What is the evidence that placing a graft helps? Is there a good evidence? Are there clinical trials? Well, when we did this clinical trial 2 years ago, there was only 2 clinical trials. One done in Australia by the group of Evans and Chen, and the other one done in Brazil by Mauricio Araújo. However, one used CBCT, which is not a good method to measure, and the other one was not really well controlled and did not measure accurately the buccal bone dimensional changes. So we undertook the trial, and basically we wanted to understand what was the graft effect. And therefore, very simply, we selected patients, we randomized, and according to the randomization, of course, some of them had a bone replacement graft, and some didn't have a bone replacement graft. And of course, we measured directly the horizontal changes as well as the vertical changes. And you see, these are some of the cases. This is a test site where we grafted. You see how beautiful the convexity of the buccal bone is. Well, you see 4 months later, that is not convex anymore, that is flat or concave. So you may think, well, in this situation the graft did not help too much. Well, let's visit some of the numbers. When we compared what happened to the gap, does it work better when we fill the gap or when we don't fill the gap? Well, actually, the gap filled better in the control group. But when we measure the horizontal dimensional change, that is the distance between the implant surface to the outer buccal bone plate, then we saw that yes, by grafting, the horizontal dimensional changes diminished. How much? Well, not too much, I would say. However, when we have very thin plates, less than 1 millimeter, then we saw a huge difference. You see, the difference was the difference between 15% horizontal resorption in the test group and 48% in the control group. So yes, indeed, grafting helped to avoid the horizontal dimensional changes in those very thin bone plates. So what are the key factors? The key factor is that this is an excellent protocol. If I can control the position of my implant and the thickness of the buccal bone plate. If I have very thin buccal bone plate, I may graft. If I have thick buccal bone plate, you don't need to graft because everything is going to be filled. The problem is what happens in the anterior maxilla, where I have the risky situations. And this is a systematic review from a group in Belgium, the group in Ghent, where they evaluated only the anterior maxilla. And they evaluated what happens if we place the implant in the ideal position, we graft the gap, and also we add a connective tissue graft. Can we improve the aesthetic situation? Well, actually yes, because in their systematic review, what they saw is that basically recession only happened in less than 10% of the cases. So of course you see how we have transformed a simple protocol, which is basically extracting a tooth and placing an implant, to a protocol that requires very strict positioning of the implant, requires the placement of a graft, requires the placement of a connective tissue graft, and requires all these factors at the same time. But of course this is the situation that occurs in the maxilla, in the anterior maxilla, where I have a very thin buccal bone. So the protocol, as we understand it today, is we try to do it without raising a flap if I have a very thin buccal bone. And it involves, of course, to first measure where my buccal bone is, because I need an intact buccal bone. And of course, involves the drilling, very careful drilling of the palatal bone wall. And of course, I need to see very well in my CBCT if I have good bone to stabilize my implant in the palatal bone. And clearly, it is very not so simple to place your implant and that the implant without bone in the buccal doesn't move outwards. And this has to be very precise. And then, of course, it will be ideal if I place a graft in order to compensate the soft tissue changes. Nowadays, we are working with collagen matrices, trying to see whether these would help in a similar manner. And there are several clinical trials that are going on right now to understand whether these collagen matrices are able to compensate for the soft tissue collapse that would always occur whenever we do an extraction. And of course, we fill the gap because we are dealing with an anterior maxillary situation. And of course, we are going to place a temporary restoration in order to maintain the soft tissues in a buccal position. So you see, this is the protocol that is not simple anymore, is rather complex, and only through the understanding of the biological changes, I think we can achieve very good results, even in risky situations. And this is just part of a clinical trial we are undertaking in order to understand what is the added value of the matrix. So in this particular clinical trial, we are doing the whole protocol, but we are adding these thick collagen matrices in order to measure the thickness, the volume of the soft tissues that is required to achieve good aesthetic results. And you see, this is one of the cases where you can evaluate the result at 3 months by doing this, and we are using digital technology to really measure the volume that we are attaining. And of course, since we are randomizing, we can really evaluate the situation in the proper manner. So, what are the key factors for success? Well, I think by now you understand that the key factor is the buccal bone. You understand that if I don't have that key factor, I need to graft within the gap. And you understand that it is important that there is a space. And in that way, I need to place my implant palatally, so I have a gap of at least 2 millimeters, and the more, the better will be. I need also to compensate the small vertical dimensional change that I will always get only because the tip of the crest is bundle bone. It's bone that belongs to the periodontal attachment, and I will lose it anyway because that bone will get lost when I do the extraction. And of course I will have a collapse of the soft tissues, only because I will lose the root prominence of the natural tooth. And if I want to compensate that soft tissue collapse, I need to use a connective tissue graft. This is the standard of care, but of course, both in Europe and here, I'm sure that your patients do not like to donate their palate. So there is a lot of research right now going on whether we can utilize collagen matrices, thick collagen matrices, to compensate that. We recently published in the journal Periodontology 2000 a review paper where we have put together all the research behind the immediate implants, and we have termed this paper From Myth to Reality, because I think it's a beautiful protocol, but we need to understand very well which is the reality. Right now, this is another study we are doing using a synthetic biomaterial, the Dentium combination of tricalcium phosphate and hydroxylapatite, and we are evaluating exactly the same what is the role of this grafting material, slowly resorbing grafting material, in the maintenance of these immediate implants. So I will summarize, because I have basically used my allocated time. In my presentation, I have tried to evaluate with you what is the evidence behind the tooth extraction and the restoration by dental implants. What is the evidence behind the preservation of the socket walls? What is the evidence of the biology of the dimensional changes that occur when I do an extraction? What are the indications for socket preservation? In my mind, there are not too many indications for socket preservation, but it works beautifully, mostly in the anterior sides and also in those critical sites where I don't have good bone to stabilize my implant. But in most of the situations, if I have good preserved socket walls, I would do an immediate implant, trying to control the factors that influence in the healing as I have described them. The problem is that I am only addressing a situation where after doing the extraction, I have preserved the alveolar socket walls. And the problem is, as I alluded at the beginning, that we don't do extractions for nothing. In many occasions, we don't have buccal bone. We don't have good bone, and therefore we will need to wait, and we will need to do completely different regenerative approaches, and this is what we call the lateral bone augmentation approaches that I'm sure I will have another chance in the future to come and lecture on that. Thank you very much.
Thank you, Dr. Sanz. Thank you for your time. We have learned much from you. Thank you very much. We'll have 5 minutes of open forum. And anybody who would like to ask any question, please approach one of the microphones along the aisle, please. And you can direct your question directly to Dr. Sanz.
Looks like everything is very clear.
I think your lecture is very interesting, Dr. Sanz. So, do you think thick collagen membrane would work? What are the possibilities that this would be better than a soft tissue replacement in your opinion?
Yes, I mean, I was careful not to use the word membrane, because the membrane is meant for a barrier effect, okay? And what I need is the opposite. I need to create a scaffold that would maintain the volume, and this scaffold would be filled with soft tissue, with vessels, with fibroblasts, and therefore I use the word matrix, because it has to be a highly porous collagen matrix that will be able to maintain the space and will be filled by blood vessels and by connective tissue cells that will replace the thickness of the tissue. The first prototypes that we tried didn't work because they collapsed by the lateral pressure of the flap. And we heard from Professor Suprum very eloquently the importance of the pressure from the flap, which I fully concord. So we need matrices that are thick enough to withstand that lateral pressure, and we are testing some new prototypes that fulfill those requirements.
Thank you very much. Thank you. Now we would like to